one of the biggest myths is that people feel like morphine kills the patient. The thing that I just want to touch on that real quick is that
Sure.
I love to have the conversation around whether or not, I always use analogies if I can, or try and relate it to somebody's own life experience, right?
Please do.
Pain keeps you up at night, right? If you're uncomfortable, right? You're just uncomfortable, you're agitated, you can't relax. And so that the morphine isn't what's going to kill somebody or sort of end their lives, right? The morphine takes the pain, which is literally the only thing they were holding on to.
Mm-hmm.
And the minute that you can get somebody to understand that removal of a link to this earthly world is pain, people are more comfortable letting that tether go. That the morphine can help alleviate the pain, which may just be blocking their ability to do what they need to do.
Welcome back, everyone. This is another episode of Healthcare Stories with Healthcare Henry, and today we have a very, very, very special guest. Emily Rivas, congratulations, newly married. Emily Cronan, how are you?
Great. I'm really glad to be here.
For those who don't know, we want to first off say we found her on LinkedIn. She is one of the first guests that we actually sought out. We saw some stuff that she talked about on LinkedIn, specifically with home care, palliative care, and hospice. And as a RN, we said, you know what? We've been trying to educate our community on what this is. You heard it from my side, the business side. Now you can hear it from the nursing side, because she is a registered nurse, certified in wound care, certified in hospice and palliative care. She's number one. Emily, welcome.
Thank you very much. I'm happy to be here.
So one of the things we do, Emily, we like people to get to know who they're talking to. So if you could, where are you from? Tell us a little bit about you.
Sure. So I'm actually from Key West, Florida originally, which is quite a trip between there and where I live now, which is Oregon. I've been a nurse since 2012. Even prior to that, I've been in healthcare since I was like 19, always in the home health and hospice space, and always predominantly in rural or like smaller communities. Portland is one of the largest places I've ever lived. I left Key West in 2017 to do a little bit of travel nursing before travel nursing got real rough, to get some additional experience across the country, learn some new patient populations. So I've lived in 7 states. I've done home care and hospice in Montgomery, Alabama, and Phoenix, Arizona. Sitka, Alaska, Seattle, Washington. I'm kind of all over the place. I got a bachelor's in 2018 and then went back through and just finished my master's in mid 2023. Super passionate about hospice specifically, and end of life care, community care, and have really done a lot of different things. I've been in every facet of this area. So I've done everything from administration to the business side, to what they call marketing or, community outreach, to the CNA work, to direct care, to leading a hospice of about 200 patients with about 35 nurses underneath me for a little while. And I once half built a program.
Yeah.
So I've kind of been all over, and I really have tried to touch every aspect of this to get a really good understanding. And I always come back to the work that we do by the bedside and trying to change the perception around hospice, because, we can't really avoid death.
So, and this is actually really interesting, because it is rare that you see someone who's a nurse, someone clinical, go into hospice so quickly. So for you, coming out of getting a nursing license in 2018, what, I guess, took you into hospice? Because for me, for most of the hospice nurses that we see, these are normally very seasoned veteran nurses. Like, they've done hospital, they've done ICU or whatever else they want to do. Then they come to hospice as a slower pace, less invasive environment. So what is it that brought you to hospice so quickly?
Sure. So I actually got lucky. I ended up accidentally becoming a clerical assistant for a hospice in my community as one of my very first jobs at a high school. And I actually decided to become a nurse because of hospice.
Wow.
There's a lot of reasons, right, where nursing is a really solid career. There's stability in income, and it is trusted, and it's also really hard. And so I just was working at this hospice and doing all kinds of different various things without a clinical license. And, I just got tired of hearing I didn't have any nursing judgment. So I was like, okay, fine, I'll go get a nursing license. And I came back to hospice and said, now I have nursing judgment. Can we carry on? Like, can we keep doing this? When I was in nursing school, I ended up, you're able to be a CNA, or used to be able to be a CNA after your first semester. And so I would work doing sitting and supportive like CNA work for hospice in conjunction with getting my schoolwork done. And it just has always been the place I wanted to be. There's so much that I like about the work as an RN. And then just to be completely honest, end of life patients are just like really special, right? There's nothing sort of, I don't have to lie to you. I don't have to pretend that you're going to get better, knowing with my clinical judgment that most likely you're not. Somebody else already told you or hopefully did, right? And I can reinforce that fact, and we can kind of get that scary piece of the maybe out of the way. And then we can focus on what's going to make it the best it can be. I don't know. That just feels so much better to me. I did my nursing practicum in the ER, and I just remember having to go and tell a family that a patient didn't make it. And it wasn't for me. I really want to be on this side when people either already know or need to be reinformed that kind of we're getting out of the way of curative, because it's such a gamble sometimes.
And that's so interesting that you say that. And this is something that I haven't talked about much, but my grandfather passed about maybe a month and a half ago. He was 98, and the institution he had prostate cancer, and they decided to do curative treatments on him and radiation. Just being frank, I won't say the specific drug that was used, but they went and they did radiation. And knowing what I know, I was like, oh gosh, this is just, one of those things. But what is the disconnect, in your opinion, from a clinical standpoint, from, hey, I can say it until I'm blue in the face, but because I'm in hospice, it comes off a little as if I'm trying to push them the other way. But the reality of it is, if you had not done this, we probably could have given you 3 to 6 months, versus doing this, you're completely zapped and now you're gone in 15, 20 days. And I see it every day. What is the disconnect between these doctors and, I hate to say, reality of the situation, but for lack of a better phrase, what is the disconnect here?
I think there's a fundamental and like philosophical difference. Okay. I think that when you are programmed in our society to be the best, do the best, go as far as you can, as long as you can, right? Anything other than that is a failure. And there is definitely a healthcare shift around holistic care and quality of life and risk benefit. But in all honesty, like, we know how much healthcare has like numerical metrics around it. And so, right, when we're talking about a patient dying on their panel, it's a failure, regardless of like how old they are or one of these things. And I think these numbers sort of like they put these blinders on these providers that like, no, we cured 73% of our patient population. Well, okay, sure. But like, is that in 6 months, or like, what do they look like in 5 years? What does that number look like in 10 years? Yep. And I think the fundamental difference as a nurse is that I actually don't care about the metrics. I mean, I have to based on my employer, but right. For the most part, I care about like what success looks like to the patient. And I don't want to trash providers, especially like oncology, who have all this science-based information regarding the efficacy of a medication. But I think that sometimes puts blinders on them, and they lose sight of the patient as a whole. 98 years old, intake's probably not where it needs to be able to manage that, right? Activity level, what are we getting to, right? Now, if this gentleman was, and again, I'm sorry for your loss, I meant to say.
Oh, no. I first time I brought it up, but it was perfect timing for that, yeah.
Yeah. If he was like rascal scooting around 12 hours a day, right? Like going to baseball games and doing all these things, sure, I could see that as very different. But an institutionalized patient, a assisted living or beyond, is already struggling with some of the activities of daily living and how much time they're spending out of their room and able to eat. And so to further hinder them just to meet some numerical metric, like a 3-month success rate or tumor growth, tumor shrinkage of 10%, those numbers don't equate to whether or not somebody is enjoying the time that they are awake, and whether it's worth it. I used to have this conversation all the time with families. One of the benefits of working all over the country is I really get a feel for the cultural differences and like regional differences. And when I worked in Montgomery, Alabama, I saw some of the hardest cases where patients are on dialysis 3 days a week and they're missing limbs and they're not able to do anything, but they just can't give up, if you will. And it's years of this. Or I'd get a patient, on hospice, he's 102, he has a tube from everywhere. And they're like, we just wanted to make, Bobby's birthday. And I'm just like, let's be honest, like, is he going to remember Bobby's birthday? Or why can't we have Bobby's birthday today? Let's just Christmas in July. Like, let's these metrics that are sort of these, but we're trained that way, right? We're trained, especially in late stage capitalism, we're truly trained to judge success based on metrics or algorithms that are numbers based, which lose the heart of the work that we do.
That's so interesting. And it's one of the things that when we try to get, one of the struggles or the back and forth we have with oncologists, right? And there's actually a Medicare rule that says if someone gets chemo and passes it within 14 or 15 days, they're coming to look at what happened. Because the question is, to your point, right, from a capital standpoint, why is Medicare paying for something that you probably had a low probability that this was actually going to work? And I always tell families that rule would not have to exist if there wasn't a need for it, right? So there's a clear-cut need for that. So that's just super, super interesting for me. And from a clinical perspective, to hear you say that, because I've always heard, well, they don't teach hospice in medical school or nursing school. Is that something that you also experienced?
Yes. Okay. And the schools are different. I went to school in 2012 in a small community. And so I was already invested in the healthcare setting. We did rotation. I think COVID has really shifted the ability to give nursing students perspective of various outlets, right? Sure. They're stuck in the hospital because that's seemingly the only place you can get a clinical placement, which is a whole nother issue. But if you don't get experience in the community setting, if you don't truly understand what the work looks like, there's no way to tell, right? And people who are new to something are going to gravitate towards something that they're at least somewhat familiar with. I hear all the time, or I used to interview all the time, ICU nurses and other nurses who were like, I'm just tired of the hospital. It's too busy. I want to do the easy work of hospice. And I'm like, well, okay. It's completely different as far as a problem, right? You're going to maybe do less like technical stuff, but boy, do you better like art and creative writing. And you really better like time management and organization, and maybe not be so freaked out by people living differently than you or bugs or, like there's so many things. Like, it's not easier. It's just different. But I do think there's not a palliative, first of all, there's not a true understanding of palliative care in our country, in my perspective, especially not when it comes to reimbursement. And then, some of the wealthier states do have these options, and then there's transition care programs in hospitals, but really we're missing like a whole gap of care where like palliative should be running concurrently with oncology the minute it's like a certain stage, and then it can run congruently till you get to hospice, but especially with home health, right? But I think societally speaking, if we're really going to look into it, like there's a Puritan undertone to our healthcare system, and death is scary and people don't want to talk about it. And so if you don't get the knowledge, if you're graded on metrics, and if you're taught that treatment and curative is the only path to success, I can see why it's difficult for providers to sort of get on board, right? They don't want to be failing their patient. And now you got to talk somebody into understanding that success can look different, which is like a conversation most healthcare consultants or hospice outreach, they don't have time for. They don't have that relationship built to give that rapport. And so you sort of hope that the oncologist throws you a curveball and you succeed at it, and then you can build your trust that way. And all the while, patients like, like your grandfather are kind of struggling because there's not somebody like pinch hitting for them yet. to build that relationship. And the facilities are another struggle. And that's a completely different component.
Yeah. And it's interesting because we talk about here in our office, we talk about palliative care and how to actually implement it better. But, and just, full transparency, the difficulty with that really is the payment structure for palliative care, right? So literally you can get paid less than what you have to pay out for the visit. Like that is a real thing. And so look at paying someone hourly, and I can't tell a nurse practitioner, hey, go to this home once a month and leave in 30 minutes. Like that's ridiculous, right? They can't get enough done. They can't, and you don't even know what kind of questions the patient's going to have, the family's going to have. So if you're paying someone by the hour, they're there for 2 hours, you actually are going to lose money on every visit. So we can talk about healthcare, but as a business model, that's not sustainable for anybody. So that's one of the hardest reasons we have to truly implement palliative care.
I would agree that without some sort of clear reimbursement structure that is meaningful, it's impossible. So there was a time like hospitals get dinged, if you will, for a rehospitalization within 30 days for
readmission. Readmission.
Yep. And so for a while, hospitals were like, all right, we're just going to start transitional care programs where a patient who discharges for CHF, a nurse calls, a nurse shows up, a nurse sends a taxi to get the patient back to the hospital for checkup. All those things were great. It's not a sustainable model for the hospital to take that cost on unless it's less than the cost of the readmission. And so I'm only using the hospital to give the example that like home health, right? I have in my past discharged a patient who's not quite ready for hospice based on a criteria, but it has met whatever the criteria is for home health to be at its plateau. And what happens is the patient goes back to the hospital because they don't have that in between, the palliative care piece, that transitional care piece. And our healthcare system is so behind the times in understanding what is happening. And so a lot of the regulation changes are like 6, 7, 8 years past due. So I think we are going to figure out palliative care, but I think it's going to be, we're just sort of drowning in this gap for now until we can figure out a way to monetize it or to clarify it enough to be able to reimburse it. It would save everybody money. I'm like from a business standpoint, like having palliative care would mitigate urgent medications coming on hospice. It would mitigate the cost to the facility for having the patient go back to the hospital again, mitigate the readmission costs. But like, how do you sell that unless there's tangible data? And it's really hard to find that when there aren't any structures for the program.
I completely agree. And it's interesting that you said that because one of the things that we know you talked about is the SB 1168 bill. Or the pay per visit bill. And I can say from my vantage point, it doesn't really work. So we call it PRN, if you will, right? And so as needed, you go out. What has been what is your perspective on that? And what do you think we need to do to really fine tune that for both the patients and the providers, and the staff as well?
Are you speaking in relation to like how that would work for palliative care or just in general for a pay per visit model in a community setting?
So specifically in the community setting and or palliative care, because in most states, palliative care will still be in the community setting.
The reason I asked the difference is because 1168 really was focusing on limiting an employer's ability to penalize or drive care based on numerical pay per visit, right? If a clinician is paid per visit, regardless of their level of integrity, the fact of the matter is they will work faster in order, to make more money. I mean, it would be great if that wasn't the case, but what happens when they do pay per visit is they drop the rate. And so the only way to maintain income, which I have the right to do, is to work potentially faster than I would if given the opportunity to do the work meaningfully. And so we were trying to prevent that from being a carrot for the employer. Essentially, that like we need nurses paid, clinicians, PTs, OTs paid what they're worth, and then we need them to be able to make clinical judgments at that time around what the patient needs. And we need that to not be a punitive thing if productivity metrics are used to force increased caseloads and things like that. So there were two components to that. How that would relate essentially to palliative care, I'm not super sure, because I think a PRN palliative care consult role is actually quite brilliant, at least temporarily. If you as a business can offset the cost of this sort of salaried employee, if you will, to be able to do on average 6 visits a month, however you salary them or however you pay them, if you can offset that cost with some of your income, then you can prevent more costly issues with some of your patients and keeps the strength of your relationships for your referral sources. So, a facility wants you to look at a patient, and the hospice nurse goes out and says they don't meet criteria, but the patient needs something. A palliative care mid-level, like NP or whomever, can help facilitate some of that coordination, whether it's with the house doc at the facility or with the primary care doc, to try and get the patient more comfortable, which makes everybody happy. And then the patient is more likely to choose your hospice or your home health, right? Like to choose your organization when the time comes. So there is a value there. But as far as it relates to 1168, we were just really trying to support nurses from feeling forced to leave a visit too early, be penalized when they need to spend more time with the patient, right? I have 5 visits on my schedule for the day, but I get to my 3rd visit and it's a visit, right? It's a problem. And then I'm there doing symptom management for 2 hours. And then I'm penalized either monetarily or putatively, like from not getting to that 5th visit in the day unless I'm willing to work 15 hours. And that is not sustainable for our workforce. And it really creates a lot of moral injury around whether or not I can actually give you the time you need, because when I walk into the house, I don't know what I'm walking into, or the facility, whatever.
So this reminds me a lot of what has happened. I've interviewed some doctors as of late, and every single one of them has said that essentially for them, that is what has changed their model, right? So if you go into a doctor's office, they used to spend, however much time they needed to spend with you. And now, for lack of a better phrase, it's kind of touch and go. It's like there's this thing where as long as I touch your knee, I can bill for you, right? Like that's really a thing. And so is that similar to what the doctors are experiencing, because they have to do so many visits to, in my opinion, make a living, right? So now they're forced to give you a 10-minute consultation.
Yeah, I think that is a very complex question when you talk about who's driving that change. CMS reimbursement rates have changed, but not that much. But a lot of independent practitioners have gone into larger health systems, and those larger health systems are driving metrics around profit margin and things like that, right? And so it also, there's this like component that is a little bit nebulous around access to care. This is a term I've heard thrown around a lot lately, and that access to care means like we have more people, they're sicker, they're everywhere, we must see more of them in order to get everybody taken care of. And I'm like, I keep reminding people that like this is a narrative that was not created by us, right? There are more people, so it's going to take more time. Not there's more people, so we have to do it faster. This idea that access to care is physically interacting with me for 30 seconds or less, or being in a facility is access to care. No, access to care is like the equitable access to have your healthcare concerns addressed and treated and educated on in the amount of time you require in order for that to be successful. That I think that I don't want to like completely blame employers, but I just am concerned about, large health systems sort of taking over these smaller clinics and starting to set productivity metrics that there really isn't an enforcement mechanism to fight against. I mean, you can, as a provider, say, I'm not going to do that, but then you're going to be without a job. Yep. And it's too expensive now to run your own practice. There's just too many complexities around our healthcare system. And so it is sort of like a snake eating its tail at this point, but there are certain areas that have not been so subversively ruined by this process, and hospice was one of them. And so I think, and home health too, like kind of really trying to make sure that we can put any legislation in place to like delay the inevitable as long as possible and allow these types of visits that are so holistic, that focus on so many different components, right? I'm a hospice social worker when I need to be, not licensed, but like those guys are great. But like sometimes I got to talk to the family about somebody's birthday, and sometimes I need to help a caregiver in a facility calm down. And there's so many things that we do and solve, and we need to be able to do that in whatever time it takes to do it. And these productivity metrics are starting to erode that ability.
So with that being said, and what we believe is coming November or of next year, right?
Mm-hmm.
Medicaid cuts, big, beautiful bill. What are your thoughts on that?
So many deep thoughts on that. My biggest concern is that people who are making decisions on these types of insurances don't actually understand where the money goes. And I don't mean that Medicaid, people have this misconception that Medicaid is just for like active poor people, like Medicaid or people who are in the older generations feel like, well, they have Medicare, so they'll be fine. And it's like, well, Medicare doesn't pay room and board. As soon as you figure out that if you are willing to put your house in a indemnitable whatever, you put your house up for sale, you use that money and you send it straight to the facility that you're going to move into, that somehow you're going to be fine. We're not, because a lot of times those patients are coming in either Medicaid pending or they get approved for dual eligibility, where Medicare pays for the healthcare costs and Medicaid pays for the room and board. Mm-hmm. Those are the people that are going to be like, I don't know where they're going to go. Like, I don't have a solution for this, but like where, these Medicaid beds are going to dry up real fast. And like, are we just going to wheel these invalid patients out into the street? Like, these are not people who can even consider surviving houseless. Mm-hmm. And these are the people that are going to be at most risk because they're the least vocal in advocacy. I don't know, in each state it's a little bit different. In Florida, we took a lot of Medicaid. In Portland or in Oregon, the hospice that I worked for did not take as much. There were other hospices that did. We had like a Care Oregon, which is like the state. So they had their own sort of organization. But I mean, I know that it's not required to accept a hospice patient on Medicaid. And then on top of that, even if you were to get a patient on Medicare who needs a higher level of care, is APS going to change its rules about what's safe in an environment, or like what's going to happen? Because there's a obligation of the hospice as well as the nurse under their own Nursing Practice Act to not allow a patient to be unsafe in their environment. So are we going to house them all in the ED forever? Where are they going to go?
Yeah, and I can tell you what I'm seeing right now. So what we're seeing right now is, and I'll speak because we're in Georgia, Illinois, and Indiana. Specifically in Georgia, the worst, because we have the largest Medicaid population that's so spread out. So Georgia's, a lot of Georgia is actually rural Georgia. People think Atlanta, but that's a very small part of Georgia. There's so many miles and miles and miles of just land where there's one house every 2 miles, whatever it is, right? So what's happening now is the nursing home, to your point, they did have dual enrollment, but now they're saying, hey, I have X amount of beds, right? Let's call it 100 beds. And 85 of those beds are supposed to be used for rehab, which pays at a rate of anywhere from $12,000 to $15,000 a month, versus my long-term care beds, which is the Medicaid beds that we talk about, that they only get paid about $4,500 a month. So what has happened is that they found a loophole. And this loophole seems to be that I can't give a long-term care patient a bed if I don't have any beds available. So that's where we're getting stuck, and these people are being sent. And you're talking about acuity levels so high, I wouldn't even put them in an assisted living facility. They've got to be in a skilled nursing facility. But to your point, that's what's happening. Or they're being stuck in the hospital and essentially just passing away in the hospital, which is terrible for the hospital because
everyone.
Now we've got to figure out, how do we get around these mortality rates, because you can't keep dinging them for something that you caused. So it's like, it's one of those things. So it's really interesting to hear your perspective on that. I don't know, to your point, I don't know what you do.
Yeah, I would say that there's another, like you brought up a point, like what are you doing with respite beds, right? Because
I can tell you.
Right, like you can't pay the facility more than what the Medicaid reimbursement rate is, right? Yep. So you can't, because that's a backdoor deal, right? Mm-hmm. I understand that, right? You don't want to get preferential treatment, but they won't accept the respite patient because it's not worth the money. And those decisions are being made by these, like, the same people who think that, like, productivity metrics are the only way to measure whether or not you're getting something done. People who have not ever done this before, who look at numbers and in these large companies, because that drives me crazy. Like, we had so many issues with respite, trying to find beds, because you're stuck between a rock and a hard place. We were willing to pay, like, fine, we'll pay the respite rate. Not allowed to do that. It's against CMS regulations. And so, and continuous care is, like, impossible to document because it requires a certain, like, 8 straight hours of nursing care, but it's like midnight to midnight, which is totally unreasonable. It became a mess. And then they don't meet GIP criteria. And so just over and over again, these patients who have inevitable situations and there's no solution for them. And then, like, the moral injury at whatever level you do this work, to just know that, like, if this, then that, but I can't do this and I can't do that. Sorry, I can't help you. Like, that's crazy. And it's only going to get worse.
Yep. And so that's what's happening here. Not as much in Chicago or Indiana, but I do see it here a lot where patients are literally just dying in the hospital. And so even when we try to move them, we have to move them to a facility that we're in. And we can only promise them, 5 days here. We still got to move you somewhere else, right? We're just getting you out of the hospital. But yeah, it has become, for those who are not wealthy, the biggest problem that I've seen in the past 10 years. Yeah. And it's only going to get larger. So I have a solution. No one's going to like it. But, the truth is, you got to get people in position of power who have actually experienced these things. Every person that makes these decisions has to at least have some point of reference to what's going on. And so when you tell me you've never actually seen a nursing home, right? These people are making that you've never seen a nursing home, so you're saying, well, they can go get jobs and still get on Medicaid. I said, oh, you've obviously never been to a nursing home ever in your life. Like, these people cannot work. So if we can get people like you, right, you should be running for office, right? You get it.
Yeah. I have great ideas. Nobody really likes them. The other thing I've seen, I read recently, and this is, of course, going to be, it's a good thing, but it's going to be driven by necessity, because corporate greed rules all. But that some of these larger hospices, right, are going to begin to have an inability to keep up their admission rates because they can't technically admit a patient who doesn't have a residence, who doesn't have a safe residence. Is they're starting to open hospice houses again. And I don't dislike this idea, as far as, if, again, we had transitional care programs come out of the fact that hospitals were tired of getting dinged for readmission rates. That's a crappy reason to do a program that you knew would be a good idea, but fine. If we get the program, we get the program. And it's kind of like that. If we get a bunch of hospice houses popping up that are a way for larger hospices to continue to provide the services that Medicare reimburses for, fine, I guess. I mean, we're just going to take over all these empty nursing homes that, go belly up and they're already set up. I think it's a great idea. It is doable, because all hospice is required to do is have the residents. So if the organization can do a hospice house, it doesn't even need to be staffed with nursing necessarily, right? It just becomes a residence. We teach caregivers to do bedside med management all the time in in-home settings. And so I wouldn't imagine it would be any different. Like, when I take care of a patient in an ALF, as long as there's somebody available to do the meds that I feel is competent and that meets whatever criteria they have to have, that's who does the meds. It doesn't have to be a traditional, like, GIP hospice house. Just be a house.
So that's interesting. And that's something that we kicked around here. We do have an example of that here in Atlanta, south of Atlanta. The thing that I've noticed, I don't think big hospices in major cities will do it, though. I'm going to tell you why. The cost of the real estate is just really too high to justify that. And then also, they don't like for the hospice house to, not that you won't get approved, but they don't like it to be a huge business. Like, they don't want it to be a 20 bed. They want something small, and it needs to be kind of quaint in a bit, right? So you got to looking at, 6 beds to 8 beds. And as from a financial standpoint, we're saying, no, I need 10 to 12 beds to make this work, right? And so that's kind of where I don't see big companies doing that. But a company around the 100 census
Mm-hmm.
all day long, all day long. Yeah.
Yeah, I'm just interested, like unless the powers that be change the regulations around what constitutes a residence,
Yeah.
they're going to stop being able to admit big company or small, right? You can't
Yeah.
provide care if there isn't a safe place to do it. Medicare has all kinds of regulations around that. And I know that in direct practice, we do all kinds of things to make the patients comfortable and figure out the community, especially if they're rural, right? I've done hospice care for patients without any electricity or running water. I've done it in homes that are not super safe because this is the best scenario that we've got, and it's not ideal, but we've made all of the appropriate referrals, and APS has no money. There are no respite beds. There's this, and the patient is still dying, all while I'm trying to figure all this out. And so I just wonder, when we don't have safe places for these predominantly elderly and isolated, marginalized populations, I mean, they're going to take up all the ED boarding beds. Somebody's going to get mad, whether it be the hospital system or the larger community-based healthcare system, and they're going to have to put them somewhere. We can't put them on an iceberg and float them off into the distance. So what do we do? I mean, not that I want that. I want to be real clear. Like, I want dignity for everybody. And like, you need to be able, right? A business is a business. I don't know how many times I hear, if our admission rate drops for too long, we're not going to be able to, right? Because you have to keep the admission rate and higher than the death rate, or you're not going to run a profitable business.
Sure.
So what are they going to do? Right? Like,
I love the idea.
It's not fleshed out, just to be clear. It's just really, yeah.
And so for me, like, even thinking about it, like the way ours is set up, the problem is that it's just not enough beds there, right? And so because it still functions almost like a personal care home, or because we still got to feed them 3 times a day, right? It's not like the regulations of an IPU, but it is still a personal care home. So they still got to get 3 meals, they still got to get a snack, and so we're getting paid as the hospice company, right? But there's no room and board fee on top of that. Unlike a nursing home, they can get the Medicare and the Medicaid to pay, so you get room and board fee and the nursing fee. So that's kind of what I see the biggest hurdle with that. Well, that's the hurdle that we're running into. Just with full transparency, it's just not profitable. Yeah. Profitable. But
and it may be that it takes, I say like a lower readmission or lower admission rates might trigger to think outside of the box because you want to keep bringing patients on. But similarly to the readmission rate, like hospitals built transitional care programs and put nurses on staff and spent the money to put a program that's not reimbursable because it was cheaper to them than being penalized for readmission. I would love to say it's because it was better for the community and the patient and the chronic condition. But in many cases, money drives innovation. And so I wonder, right, what that's going to look like when we just don't have a plate. Like, it's comical in a really morbid way that, like, what are we going to do? Like, wheel people out of the hospital and like put them on the side of the road? Like, you have to put these human beings somewhere because we have not come to terms with the societal norm that that's okay to not. So we've got to find some sort of policy or some sort of process that aligns with what we are going to do, which is why all of our EDs are overwhelmed with boarders, because there aren't safe places to put people because there's no reimbursement structure for it. So we're just, I don't know, it's like a critical mass. It is really a difficult time to be a hospice nurse or to be a nurse in general, but also I find it really interesting, like fascinating, because I think we're on the cusp of a huge transition in the way that we approach healthcare in this country. It's got to get worse before it gets better, but I do feel like in our lifetime that it's just going to look substantially different than it did before COVID and like it does now.
Knowing what you know now, would you still be a nurse?
Absolutely.
Yeah.
Absolutely. I joke all the time that, first of all, there's like nothing I could do at this point. I'm too far gone. I've been doing this too long. But like legitimately, the difficulties that I have with hospice are really system based, and they're the same problems that we face in any other industry. Doing the work and seeing the success of that and recognizing that like it's a calling in the sense that like not everybody can do end of life care. People don't like to talk about death. It freaks them out. It's uncomfortable. It's and I don't have any problem doing it. And so therefore I should do it. And it's like that fundamentally simple. Like, why do you do hospice? Because I can. There's
Yeah.
so many people that can't. I can't
Yeah.
do
Yeah.
lots of other things, and
Yeah.
hopefully people do that
Same
instead.
here. Same here. Yep.
Yeah.
Yeah. So as we go into, I guess, what, in your opinion, my opinion, one of the craziest healthcare times. I think you're probably relatively young, like I am. I'm 36, right? You're probably younger than me.
No,
You really?
37. I'm 37.
Okay. Am I 37?
So like same age.
I think I might be 37. I am. 88.
87.
80. Okay. 88. So yeah.
Yeah.
Okay. So one of the things is like, I look at, and I think maybe you can give me some insight on this, right? I look at us as being because hospice is relatively new, 1990s, really, right? Late 90s.
Yep. Late 80s.
So
Yep.
a lot of people really haven't seen it. Is that really why there's such a huge education barrier? Because we're the first ones really explaining it to people and helping them say, hey, you're not just going here to die. And they're like, also, just to get your views on it, do you find that talking to minorities is a different conversation than talking to other people? And if so, what does that look like?
Yes. So two parts, definitely on minorities for a lot of different reasons. A lot of it is cultural, which is, again, like, it's also regional. It's not even necessarily like a race of any kind. It's sort of like what the culture is in the environment in which people live. I'll use Montgomery. I'll go to the other part in a minute because I'm really passionate about this piece. Going to Montgomery, right? It is a larger Black population, and it has a lower, like, annual salary and lower education level. These are just metrics like that exist. But it didn't matter what color I was dealing with when I talked to somebody about end of life. It just culturally was not accepted. Culturally, in that community, do everything until the end of time, right? That like having to break down somebody and be like, it is okay to be tired and be done. And that not feel like your own personal failure to your grandkids is just a deep, hard conversation to have. And not, some people don't ever get there. But I love the ability to get somebody there before it is too late, right? This idea that like you're just going to hospice to die. Well, the fact of the matter is you can go to hospice to die, you can go to the hospital to die, you can stay home and die, you still gonna die. Like there's not a chance that like we're gonna have this conversation 2 years from now and you're gonna look better than you look right now. That, like, no oncologist is going to tell you that you're going to, you may still be here, but today is going to be probably closest to the best day that you're going to have. If you get with me and I get rid of all your terrible medications, you might feel great for a few weeks, but overall, right? Like, so it's just that like, you have to open up the conversation to like, you got to figure out where you want to die. Nobody is going to stop you from doing so. I think there's a huge mistrust with the healthcare system in general, right? I am in the healthcare system and I have trouble trusting some of the processes and systems. And the more I understand statutes and legislature and regulations, the like more frustrating it gets in its own way. So, you have to build rapport with people. And I love to get people where they need to be so that we can get everything out of the way. I always say, like, I'm gonna get everything out of the way for you, and then you're gonna do whatever you want to do, right? I'm not here to steer the ship. I might not even be on the ship, but like, and it's a different approach in different communities. Living in Portland, Oregon, there's less of that, but I find that there's a lot of resistance in the facility caregivers who tend to have different cultural backgrounds than the majority of the Pacific Northwest, which tends to lean predominantly white. And so there's this component, especially around feeding. There's a huge one that I find in a lot of like cultures, Hispanic, like mine, Black culture, like Filipino, like just a lot of the feeding is love. And so the act of not forcing food is an act of neglect. And so navigating that, I think there's so many ways and so many like components to that. I think overall, as a nurse, I've had the ability to recognize that like stereotypes inherently are not bad, right? When they're used to profile somebody in a negative light, sure. But I need to understand you and if you come from culture X, the commonalities around culture X are a really great place for me to start. I shouldn't pigeonhole you into that, but knowing that fact makes it easier for me to approach you at the level you want to be seen.
Mhm.
And so that, knowing that there is a commonality and mistrust around healthcare, I don't come in and say, I'm ripping all your medications away on the very first day. You've been in dialysis with one arm and no legs for 6 months. I'm gonna come in here and be like, nope, stop this, stop this, stop this. And you're not gonna think I'm harming you.
Yeah.
I gotta get there gently because I know that there's a pretty good chance you don't trust the healthcare system. And based on the fact that you have all these tubes, that you don't believe in quitting, right? Like there's a component to that, right? And so, yeah. And then, can you tell me the first part of your question again? I forgot.
So
about the one part.
So you're very passionate about the differences in minorities and culture, and the other one was about because we're the first of our generation to educate them. Is that why it's so hard? Like, what is it that they can't wrap their mind around this concept? Is it because, well, I guess, why do they, what is it that we're facing that they're just like, hey, I can talk to someone and I'm blue in the face. At the end of the conversation, you're saying, well, I'm not going to let you come in here and morphine mom to death. Right. What is that about? Right. As from a clinical standpoint, what is that?
I think you're right. I think it's a generational shift in perspective and philosophy around ourselves, right? It's the same conversation you have around seeking therapy for grief to, older generation family members, right? They don't need a therapist. I don't talk about my feelings, right? They were raised by the silent generation.
Yeah.
So there's definitely, I think you're right. I think that it's a combination between a generation that didn't approach healthcare that way. Their doctor was always right? We were the first generation, well, maybe Gen X, to really question your provider, right? And so when the doctor in oncology says, we're just going to give you this med, it doesn't matter who tells you that this is not going to be comfortable for you. The doctor made that comment, and so that they're right. And I think that we're a generation who hasn't been educated around death and dying and end of life anywhere in our, it's not part of education, not part of healthcare education. They don't even talk about it in CNA school, if you will. They barely talk about it in nursing. There are programs that are trying to approach that, but just like our healthcare system regulations, the education system, the fundamental structure takes a very long time to change. And those lag measures can take a decade to really be seen in practice, in perspective. And I think that's what we're seeing. I'm finding that I'm seeing later hospice admission, but not because of a philosophical distrust of hospice, because short staffing has resulted in not catching things sooner. So that may be another problem you're facing. Like, I'm finding that, like, in facilities, I'm getting a patient who's had 6 months of weight loss and PPS decline and cognitive decline, but because they're so short staffed and they're pulling teenagers off the street to try and provide the care that don't get the training they need to kind of see these things. And the nurses are, at the facilities less and less, they're stretched. And so they're not doing the weekly weight check-ins and hey, Mrs. Jones has been really down lately, and I haven't seen her come to bingo for the last 4 bingos, right? You're not getting that. You're only getting it once the patient can't get out of bed, which hurts everybody, including hospice's bottom line, to be, completely honest, right? You need these admissions early for many reasons. Because your model isn't, or the hospice model, that reimbursement model is not great. If you're getting, your length of stay is 7 days, you're losing money at that point, right?
Yeah. It's interesting that you say that, because one of the things that we're seeing more than ever now is that it looks like hospices are actually accepting patients much later. And so I've always wondered why, because I'm seeing 2 major shifts in the market in urban communities. One, I'm calling them fake graduations, because that's what they are, right? We're kicking people off of hospice, yet they still need all the hospice services. But what we figured out is, hey, if I can take this person on early, another hospice doesn't want to absorb those costs. They're gonna have to pay back either. So we'll just kick them off and they have no help when they actually need it. That's one of the big things that I'm seeing in urban cities, because a lot of we built our business on transfers, right?
Okay.
I was in any hospital business for 8-9 years. I could go tell blue in the face, they were not going to work with African-American. It's a fact. Everyone in this city knows it, right? So now I had to go through a lot to kind of build my presence. And now the community is what has brought us back into this space where we want to use him. So give us Henry. And that's kind of how we built Precious Hospice. But I'm seeing a lot of these graduations. I'm like, we're getting calls from transfers. I'm like, you've been on hospice for 4 years. You're actually declining now and they want to kick you off. It's insane to me. Are you seeing a lot of that where you are?
No,
Okay.
not here, which is, I mean, that's great to hear. We have, and again, it depends on the organization you work with, right? I have been demonizing metrics for most of this conversation. I don't want to entirely, because reviewing long length of stay, commonalities, making sure that you don't have the same diagnoses across the board, right? Those are huge red flags for waste, fraud, abuse, all of that. So very rarely do we want a hospice patient on for 3 years. I'm not saying that it's not possible, but you want to kind of look at whether or not that's valuable either. So what we're seeing is more along the lines of just getting them too late, right? It's not a question of bringing them on because they have an eligible criteria, and then we make them really happy and they get their hospice honeymoon, and then they stick to being healthy, wealthy, and wise. And then right as they start to get sick, we're like, well, we don't really want to pay for that, so we're going to throw them off. So I have not seen that. I have not heard that in our community, which is very positive. I hate it. I hate that. That makes me very angry. I don't love it, because a lot of times, when you talk about bringing somebody on hospice, I have to have that conversation too, where I'm just like, they're probably going to get better, y'all. Just so they're not going to stay better, but there's a pretty good chance that if I take away the 73 medications that they have been on for 45 years, that they're going to eat more. They're not going to be nauseous. They'll probably sleep better, and they'll feel clearer headed and may end up improving. And also, all of a sudden, we're going to send in a CNA to help them get ready. That's their own personal person.
Thank you.
Yeah, and we're going to send we're going to send a social worker there to talk about their lives. We're going to do a meaningful legacy project that, we're going to build a quilt that they've been trying to get to for 40 years. And all of a sudden they're out playing bingo, and they're like, she's healed. I'm like, no, but here's what's going to happen. So I have to have that conversation too. I love a good hospice honeymoon. I'm like, I get patients all the time that would they're lactose intolerant, or I don't know, they're sugar, the diabetes, right? And so they love ice cream, but they haven't eaten it for 40 years. And I'm like, you know what you can have anytime you want?
Anything you want.
Anything you want.
Any flavor, whatever. Yeah.
Yep. Yeah. I'm not going to send you into a diabetic coma, but pretty good chance that your metformin that you've been on for 38 years is going to do it when you're eating 23% of 2 meals a day. You know what? Magic cup them. Let's do it.
That is so interesting. So for me, I love this, and I definitely want to bring you back for part 2.
Okay.
I think this is phenomenal, and I think we're just now even getting to the real spot where I'm like, oh my God, now somebody who finally gets it. And it's interesting because originally we started this podcast, we called it Hospice Saved My Life. So our first one, that literally was the name of it. And then we're like, okay, we can't say that, right? Lawyer says you can't say hospice. And we're like, seriously, come on, man. It's just the name of the podcast. So, and that's even on my billboard in Atlanta. That's what it says. Hospice can save lives. We have to change that. But it can, because to your point, right? You're going from no help at all to a CNA, a nurse, medication, supplies, equipment, and you're not paying for any of this stuff out of pocket. Right. Well, no, you're absolutely right. So,
and somebody who listens to you, right?
You're preaching. You're preaching today. You're preaching.
Yeah, I'm just here to hang out, man. You tell me how you want to be cared for. I'm just here to hang out, And I'm like, let's hear all this. Gone. I don't want to. I want you on 3 medications max.
Yes. It's like we're gonna DC everything out the gate. That's one of the questions they ask us. Are you gonna DC all of our meds? No, that's not. It's a process, right? Because if we DC everything at one time, that can happen, or you can just collapse tomorrow, right?
Right.
I don't know why, but if that was my perception of hospice, I wouldn't want to do it either, right? And so you're You're right. So
Yeah, and that's what I mean by when you're talking about approaching minorities, especially, is recognizing culturally like some of the commonalities around how to have these difficult conversations, right? I can provide hospice care to a family and never mention death once. I don't we can do it all. It's all based on like focusing on you. And so there's certain families that want honesty around, well, how many, the question, how long do you think? And I'm like, all right, wait, I don't play this game. But some families are really, really sort of focused on, not having their loved one suffer or linger when they don't need to. And then others who are like, can't stand the D word. And I'm like, cool, we can do this either way. And my job is to just approach it how you want. And yes, but I would love to remove all of the medications except for 3 for almost every patient all the time, and then magic cup them all. And
you're right. And I just got to ask this because I've never said this out loud. This is another one I said out loud. So my mother, she was on my hospice in 2022. She was on for 3 months. This was the craziest thing for me. And by the way, I'm not clinical at all. I had it down to 5 days when she would pass from the day she came on. And everyone was like, no. I said, I guarantee you, I have seen this 100 times in the past 6 months. This is how this works. It's like, well, I don't care what she does. All she can do is create a space where she's more comfortable or less comfortable. Mm-hmm. But if she's eating this much food, she's moving this much. I had it down to within 5 days. And once we got within 5 days, I had it down to 6 hours. Mm-hmm. They were like, oh my God. I said, I'm telling you that like everybody's the same. Like they're like, well, no, everyone's different. I said, no. When I see these disease processes, unless there's something very, very different, right? This person is on medical marijuana, which I'm saying that does extend people's lives. No one wants to talk about it, but I'm seeing that extended a lot. And if for no other reason, they're eating all day long. Right. Mm-hmm. So I'm seeing that. But other than that, I'm like, man, I can kind of walk into a patient's house. Even my granddad, I saw him in the hospital after the radiation. I said, 2 weeks. He died in 15 days. Mm-hmm. To the T, 15 days. Is that something that you also feel like, okay, I've gotten a pretty good eye on this now? Okay.
Yes. I mean, there's definitely, clinically speaking, there's certain criteria where we would deem a patient imminent, right? Mm-hmm. Sure. There's certain respiratory things and certain components, mm-hmm. but outside of that sort of imminent, like they're in the active dying phase, yeah, you can. And if you get a chance to know your patient, it's even easier. You can clear and like you had mentioned earlier that one of the biggest myths is that people feel like morphine kills the patient. The thing that I just want to touch on that real quick is that sure. I love to have the conversation around whether or not, I always use analogies if I can, or try and relate it to somebody's own life experience, right? Pain keeps you up at night, right? If you're uncomfortable, right? You're just uncomfortable. You're agitated. You can't relax. And so that the morphine isn't what's going to kill somebody or sort of end their lives, right? The morphine takes the pain, which is literally the only thing they were holding on to. Mm-hmm. And the minute that you can get somebody to understand that removal of a link to this earthly world is pain, people are more comfortable letting that tether go. That the morphine can help alleviate the pain, which may just be blocking their ability to do what they need to do. I also talk a lot about a gate, and it's not that it has any religious connotation. It can. I sort of approach it like however people want to hear it, is that when you walk through a gate, you do not walk through a gate all at the same time. You do not you're not here and then here, right? Your leg goes through, your arm goes through, half your body. Like there's a point where you're in between the gate. Yes. This is what the active dying phase in that little space is that like, is it just a leg? Granted, it's obviously like an analogy that you need a little bit of imagination for. Yeah. But when you tell somebody you cannot transport from one side to another without taking a step, that a lot of the active dying phase and some of this in between is that step. It's just somewhere in that step in time. It's not the same like as it is to us at that point. Those two things work really well to kind of alleviate people's concerns around whether or not they just killed their mother because they gave them 0.25, milligrams of, morphine 3 hours ago on a person who hasn't eaten in 9 days, right? Like, they're just like, oh, it was it. I'm like, well, something has to be it, right? You take all last breath, something did it. But it's really about the tether being that they're not here with us any longer, per se, that the physical tether is pain. And or struggling to, for air. And that struggle shouldn't be the last tether, right? We want to release that tether and let people do what they need to do. And that seems to work really well.
Emily, I appreciate it. So any last thing you want to leave them with? I'm going to try to get you back for a part 2.
Okay.
I'd
be happy to. I love to talk about this stuff so much. I know we were all over the place too, so I have a tendency to do that.
No, I love it. And we'll get you back because we just now started getting into the hospice portion. We spent the whole hour learning who you were and how smart you are. And now we're like, oh my God, this is perfect. She actually gets it. Because there are people in hospice that don't get it. Like they just literally don't get it. Like we have to constantly train them, or someone coming from ICU to hospice, like, whoa, that's not what we do here, right? That's not what we do. So you get it. Is there any last thing you would leave with? 2-part, the student who is going into nursing and the family who's struggling with accepting hospice.
Sure. For a student going into nursing, like find a way to job shadow. Find a way to interact with a hospice in the community and see if it's something that you enjoy. So I would say the same thing for home health, but I mean more for hospice. But sure. You walk in and you either know you love this work, even if you don't fully understand it, or you're like, nope, that's not for me. Right. I think it's just like, as a nurse, anything, I knew right away I didn't want to do OBGYN. Knew it. It's not for me. I'm not interested. And I think that when you're going into school and you're kind of like looking for your specialty, you can kind of like intuitively know what might be a good fit. And for that nursing student, also know it's going to take you 2 years before you actually feel like you know what you're doing. Like you need to be okay with that. Mm-hmm. Community care is not structured in the same way. And it's a little scary, but you gain confidence a lot faster. So. Mm-hmm. And then for the family struggling, right, I really wish that families who are on the fence would just seek to have a conversation with someone in hospice of any kind, right? Consults, I know you go out and you maybe meet with the family, but like they just need to have the conversation with somebody who has gone through it to understand how beneficial quality of life is. This is the only time I feel like that insurance will reimburse 100% of you just getting exactly what you want, right? Like when else are you going to have all these things? Like we're here to help and like someone else is going to pay for it. Nowhere else in our healthcare system does that happen. No other care setting at no other point in our lives. And so I also say this one works really well too, is that like, we really only get one shot. I don't really deal in repeat customers. So like, we have one shot to do this right. And it may be a little bit of stutter, but we have to take a step in the right direction. And I feel like hospice is that right first step. Yep.
I appreciate it, Emily. I'm going to get it set up. I'm even thinking we go live with it the next time so people can ask questions in real time. Because you were good that we don't even have to edit anything. Like, that's why I'm like, oh my, I'm going to get on the phone and tell them right away. This is perfect. I love this. Okay. This is very awesome. And
great. This is really fun for me too. So
yeah, I love this. So we'll circle back and then we'll come back and then we'll get you back on.
Okay. That sounds great. It was really great to talk with you.
Thanks, Emily.